Hello everyone, and welcome to CRAMSURG, Clinical Research Appraisal and Methodology for Surgical Trainees, where we pick a paper fresh from the press on a hot general surgical topic. We review it for you, we present it for you, we critique its methodology for you, and provide top-of-the-field expert opinion and teaching on research appraisal and methodology. My name is Gio Perrin, and together with Professor Sababala Subramanian and Maria Digby, we bring you CRAMSURG from the wonderful region of the Yorkshire and the Humber.
Welcome back everyone. Today we have a paper from the World Journal of Surgery entitled Pulmonary Recruitment Maneuver Reduces Shoulder Pain and Nausea after Laparoscopic Cholecystectomy, a randomized controlled trial. Following our presentation, Prof. Saba is going to talk about evidence-based medicine for surgeons and trainees. This will be the first part of a few sessions on evidence-based medicine. We'll be digging deeper and deeper into the meaning of evidence-based medicine and how to apply it to our clinical practice. Enjoy!
Good evening, everyone. My name is Ahmed Ali, and I'm one of the core surgical trainees in general surgery at Pinderfields Hospital. So I'll be presenting today with Mr. Giordano Perrin, who's one of my registrars, and the moderator for today's session will be Prof. Saba. So the paper that we've selected is titled Pulmonary Recruitment Maneuver Reduces Shoulder Pain and Nausea After Laparoscopic Cholecystectomy, Randomized Controlled Trial. It's a study that was carried out in Sweden and was published in September of this year, online only so far, in the World Journal of Surgery.
So we do know from previous papers that we discussed, and we've also probably all come across, that there is a relationship between CO2 insufflation and pain. The degree on hemoperitoneum, we know we've discussed this in episode 18 when we touched on the PAROS trial, does affect the degree of pain and the degree speed of recovery after a laparoscopic procedure. And we do also have some evidence from gynecological surgery, mostly, but also from bariatric surgery, that an evacuation maneuver post-op via pulmonary recruitment can actually help and reduce pain. The two biological mechanisms that are supporting this phenomenon are mechanical, so there's less volume in the abdomen, therefore less stretch, therefore less pain, and biochemical. CO2, as you know, when it gets in contact with water, gets turned into carbonic acid that obviously can dissociate and cause acidity, which is a known factor that can cause pain.
So I'll just give you a quick introduction to the aims of the study as mentioned by the authors. So they were hoping to investigate the postoperative pain and, as a secondary measure, nausea as well, when performing a ventilator-piloted pulmonary recruitment maneuver at the end of laparoscopic cholecystectomy. So they only included elective cases in this study. So if we use a PICO format to just outline their aim, we can say that the patients are those undergoing an elective lap chole. The intervention was whether they received a pulmonary recruitment maneuver or not, in addition to just applying gentle pressure to the abdomen. And the maneuver that they performed was 6 breaths over a 1 minute period with a total pressure of 40 centimeters of water. And the comparison that they have is whether the group received the PRM maneuver or not. And the outcome is the overall pain in 48 hours.
Yeah, sure.
So,
they designed this as a prospective, which is redundant as a word itself, double-blind randomized controlled trial. This was carried on between 2014 and 2018, October to December. And the inclusion criteria, as Ahmed kind of mentioned, are being an adult, so 18 years old or older, ASA 1 or 2, which means basically minimal amount of comorbidities, and having an elective laparoscopic cholecystectomy for symptomatic, non-complicated gallstone disease, which means excluding cases of pancreatitis, cases of cholecystitis, or CBD stones. Also of note, where the authors conducted this trial, in order to have a laparoscopic cholecystectomy, you have to be smoke-free for 6 months. Which is quite impressive and probably a great way of cutting the waiting list for the NHS as well. Enrollment was consecutive, so everybody that was coming through the door and having an operation, and randomization was conducted in blocks. And as Ahmed mentioned, the two groups are passive evacuation plus pulmonary recruitment maneuver versus a simple passive evacuation. Double blinding means obviously patient and assessor were blinded to the intervention. Surgeon, although it would potentially be possible, it would be quite difficult to do, and the authors didn't attempt it. So ball back to you, Ahmed.
Yeah. So just elaborating on the methods, that we've just created this simple flow diagram just to illustrate everything. So it's important to know that preoperatively, all of the patients received oral paracetamol as their analgesia of choice. And as the patient was taken to theatre and was anaesthetised, they were also had an envelope with them which was handed over to the anaesthetist. And this had the allocation from the randomization sequence to see which intervention, or whether they'd received the intervention or whether they'd received the control. Then post-operatively, the patients would complete questionnaires over a 48-hour period, which were then assessed and put into the database by a different individual. So the patients and the people present during the procedure were not aware of the outcomes from their questionnaires. So we talked about the preoperative analgesia, which was paracetamol. It's important to know that there were some differences in the anesthetic choices that they had. So induction was either remifentanil and propofol or alfentanil and thiopental, depending on whether the patients had GORD or not. If they did suffer from GORD, the latter option was used. Maintenance throughout the procedure also remained the same from an analgesic perspective, where everybody received remifentanil. However, from a hypnotic perspective, patients either received propofol or sevoflurane. All of the patients at the end of the operation received local anesthetic, which was 20 ml of bupivacaine hydrochloride, 5 milligrams per 5 ml, plus adrenaline 5 micrograms per milliliter. In addition to that, analgesia was also prophylactically administered to all of the patients. They all received 30 milligrams of IV ketorolac, which is a very strong NSAID that's not particularly used here in the United Kingdom, plus or minus additional IV morphine as well. In anticipation for the nausea and vomiting that the patients might experience, they also administered IV antiemetics. All of the patients received IV droperidol plus IV betamethasone. Again, both of these aren't too commonly used here in the UK. And if the patients had a background of post-operative nausea and vomiting, they were given an additional dose of IV ondansetron. Post-operatively, the patients received, again, paracetamol, QDS as a regular medication. And if they required some additional analgesia, they had 5 milligrams of oxycodone offered to them. Again, it doesn't really follow the analgesic ladder, whereas here in this country, we would typically work our way up by giving them ibuprofen, codeine, etc. And if the patients did feel any nausea or did suffer from any vomiting, they could also receive PRN ondansetron. So, Gio, do you just want to quickly talk about the outcomes?
Of course. So, as mentioned earlier on, I just want to stress this out a little bit more. The primary outcome of this study is overall pain. Doesn't matter what the pain is overall pain, and particularly the mean pain score at 48 hours, as measured throughout the postoperative period. It is important to point this out because this is what they use to perform their sample size calculation. And they presume that there will be a 2-point difference in favor of the pulmonary recruitment maneuver against standard treatment. And they calculate that they need about 69 patients per group. And there are some consequences of this that we'll talk about later, but yeah, remember this for the moment. Secondary outcomes are nausea and vomiting, and shoulder pain and wound pain. And this is measured at 4, 12, 24, 36 hours. And obviously everything is measured in VAS. A variety of other secondary outcomes are also included, such as analgesic cues, etc., etc. We'll talk about some of them in more details later on.
So just highlighting the patients that were recruited initially and those that were actually analysed in the end. So 260 patients were initially randomised into the two groups, 130 each. However, there were certain exclusions on patients that were not analysed, either because the patients didn't receive the intervention, either they were excluded after being reassessed and they realised that the patients didn't meet the eligibility criteria, or if they had an extra surgical intervention, ERCP, or have any complications, as discussed before. There was quite a significant number that were lost to follow-up in both groups as well, as we can see. But the number of individuals in each group ended up being 76 individuals in the intervention group and 71 in the control group, therefore sort of meeting the requirement of at least 69 patients in each, based on the sample size calculation.
Yeah. So as mentioned, the overall pain is the primary outcome, and there is no difference between the two groups. in terms of incidence or intensity, nor as mean overall the 48 hours period, or as any time points where this outcome was evaluated, as you can see from the chart. And this is quite important to highlight, because if you just read the conclusion of the paper, this might escape you. And we'll talk about it later. So ball to you, Ahmed.
So just talking about the secondary outcomes that were investigated. So in addition to the overall pain that patients were experiencing, the incidence of shoulder pain was also measured between the two groups, and it was found that it was significantly lower in the PRM intervention group compared to the control. Nausea was also assessed in both, and it was found to be significantly lower in the PRM group, and it also had a significantly lower intensity. It's important to know that the intensity reported in both groups was quite low, as you can see on the graph on the right-hand side. So 1 to 2 out of the 10-point scale that they used. They also recorded the number of patients that have vomited 4 hours post-op. So 0% of the patients in the intervention group vomited, whereas 13% did in the control group. Again, a significant difference. And mobility was also assessed to see how comfortable the patients were post-operatively at 4 hours. And again, there's a significantly high number of people that were able to mobilize in the intervention group compared to the control. So we'll just be talking about the limitations of this study next, and the research group commented on 3 limitations themselves. One being the varying post-operative care based on the individuals that were receiving the analgesia and the antiemetics. And as an additional measure, they noted that some patients were also administered NSAIDs as well in both of the groups. It's important to know that in their results section, they did comment on this, and they measured the number of patients that were receiving all of these medications, and there was no significant difference between the two groups. They were also able to appreciate that exclusion after randomization is also a limitation. And as we discussed before, there was a difference in the types of anesthetic that the patients had received.
Yeah, so the first of sort of the other limitations listed here is kind of redundant. But just to stress out that the primary outcome was actually not different between the two groups. If you just read the title and the conclusion of the paper as it's written, this doesn't seem to transpire very much. There is definitely a halo effect here. Ahmed explained very well how the postoperative analgesic protocols is based on a PRN set of medications. And obviously, if you know that a study is going on, even if you're blinded to what intervention the patient had, you're going to be keen to ask more if they need such medications. The primary outcome is obviously subjective to a certain extent, although is evaluated in a standardized way. Is a limitation, but is also a pretty standard way of doing it throughout the literature. So I don't think we can criticize them too much for that. The main point that I think we should highlight is that there are a lot of external validity issues. Now, starting from pre-op, patients are heavily selected. As I mentioned, only elective laparoscopic cholecystectomy for uncomplicated gallstone disease, that would, at the moment, take out of the picture pretty much the vast majority of lap choles that we do. Also, people that can be enrolled needs not to smoke for 6 months. Again, that's not really practical here. It's not something we can do. Intraoperatively, they say that the operation can be carried out by any sort of level surgeon, trainee, or fully trained surgeon. So this does have some sort of pragmatism to it. But they also perform a cholangiogram as a standard procedure, and they do perform an ERCP intraoperatively or the following day after the operation, which again is not something that we would do, or most surgeons would do an OTC only if they think is needed. And postoperatively, they use medications that we normally not use. Ketorolac is a fantastic drug, but we don't really have it readily available in this country. They also excluded BMA from ASA. So morbid obesity would not give you an ASA score, which normally it does. And I'm not entirely sure why they've done that. There is a high dropout rate, which led them to, because they identified that halfway through the trial, increase the recruitment number and then end up with slightly over-recruited group 76 and 71 versus the 69 they were originally planning.
Yeah, so I think a conclusion that we can take from this study is that a pulmonary recruitment maneuver should be recommended to reduce post-operative nausea and shoulder pain. And then we've just summarised the main points in the table below as well. So thank you very much.
As usual, a brief summary of the discussion session. So as highlighted a few times throughout the presentation, we feel that it is important to highlight that the primary outcome of this study was overall pain after the surgical procedure. And for this particular outcome, there was no difference between the two groups. We should always be careful about the interpretation of p-values and statistical significance in secondary outcomes of a randomized clinical trial. A further very important point that we discussed is related to the intention to treat principle and external validity. Particularly two groups of patients we feel should have been included in the main analysis. And this would be patients that suffer from a complication and patients that underwent an ERCP following identification of CBD stones. Given that if randomization is effective, these two groups should be equally distributed between the two arms of the study. I think in a pragmatic intention to treat randomized clinical trial, they should not be excluded, particularly as this happened after randomization. An option would have been for the authors to present both results with and without those patients. Furthermore, it is difficult to particularly pinpoint why there has been a reduction in the shoulder pain in intervention group and a reduction of wound pain in the control group. And we feel that the number of variables implicated in this phenomenon might be beyond, could be appreciated in this particular context. And finally, a philosophical issue that relates to the need for this particular RCT. The authors published a previous study on bariatric surgical patients, which highlighted how overall pain was reduced in presence of the pulmonary recruitment maneuver. So the argument would be that this should be easily translatable into any other laparoscopic procedure, really. There are two issues here. One is that the population in the previous study is specifically bariatric, and this might not be applicable to a different population. And furthermore, there is the issue of replicability. And this trial actually shows how the results that the authors picked up on the previous study are not replicable in this context, as the overall pain, as mentioned earlier on, is not different between the two groups. Right, I'll leave you to Professor Saba's lecture on evidence-based medicine. Thank you.
So I thought we will we'll talk about evidence-based practice in general, and I thought we should do a few sessions on just discussing or giving an introduction to evidence-based practice. Okay, so this is the first of those talks. So what we'll talk about today is go over what evidence-based practice is, or what EBM is, and why we as surgeons and trainees need to practice evidence-based medicine. And I'll go through some pitfalls in evidence-based medicine that we need to think about. And I'm sure all of you have heard of this phrase, evidence-based medicine and evidence-based practice. And I thought it would be helpful to just refresh some of these basic concepts. Right, so here's the definition of evidence-based practice, right? This was from one of David Sackett's paper. He is considered as one of the fathers of evidence-based practice. And he said, this is the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. And then he went on to say that this is integrating individual clinical expertise with the best available external clinical evidence from systematic research. Okay, so let's just dwell on that a little bit. So essentially, he says, you make use of, you make use of clinical expertise and best available evidence, put them together along with what the patient would like to have done, and that, in a sense, will help you practice evidence-based medicine. In other words, it'll help you make decisions about the care of your patients. Now, what is a clinical expertise? Now, let's just take something that most surgical trainees would be familiar with, i.e. the setting of acute appendicitis. And let's just think about the diagnosis of acute appendicitis. Now, in the diagnosis of acute appendicitis, I'm sure you'll agree that there is expertise involved. And this expertise incorporates clinical judgment and also proficiency. And you get judgment and proficiency from knowledge about the anatomy of the appendix, the physiology and pathophysiology of appendicitis, the natural history, and so on. And you also get better by practice, by seeing more and more patients with right iliac fossa pain. And with experience, you are able to make better judgments. Okay, so that's common sense. Now, what we are saying, or what the proponents of EBM say, is that this alone isn't sufficient. And you also need to draw upon data or evidence on diagnostic tests to be able to then decide which diagnostic accuracy studies. They may even be clinical signs like the SOAS sign or the Roth-Singh sign, or blood tests like the CRP and white cell count, or clinical scores like the AAR score, and studies on imaging and so on. So it's important to keep ourselves up to date with the evidence base, in addition to the expertise that we gain with practice and experience, to then decide what to do next in a patient presenting with acute appendicitis. And last but not the least, you have to fit in or include or incorporate patient values in your decision making. It may not necessarily fit in with what you consider best as the next thing to do. For example, if you're thinking of a CT scan, and the patient wants to particularly avoid exposure to radiation, you will need to accommodate their expectations and the preferences. Not to mention specific issues that are important in individual patients, like allergies to contrast or morbid obesity and so on and so forth, when you're deciding on, let's say, doing a CT scan. Okay, so why is this important? Now, traditionally, we have relied on books. We've relied on received wisdom and how things are generally done in the place that you did your training. And you often hear people talking about our experience. In our unit, this is how we do it. This is how we've always done it, and it's always worked for us. Now, the problem with that is, as you might imagine, that is considered inadequate. And if you move from one unit to another, you might find that the practices are very different practices with regards to diagnosing appendicitis. And I hope you'll agree that this is also an unreliable sort of set of evidence to base your decisions on. Now, the other issue is that people would often say in the past, when I say past, I mean several decades ago, that this particular test should work because it makes biological sense. There is this pathophysiological rationale for this. But basing your decisions on mechanistic explanations or pathophysiology is often unreliable. And that's why you need evidence-based medicine, because evidence-based medicine tells you to rely on empiric data, not just on theory. Has it actually worked in the real world? Has it actually been tried in patients, and what have the results shown you? Okay. And expertise alone, clinical expertise alone, as we've discussed, is inadequate to guide your decisions without empiric data. A lot of people would say, I base my decisions on my experience, but that experience is also empiric data, and experience is not great data because, as you might imagine, it often depends on your recollection of your experience. And there's good evidence to suggest that if you ignore empiric data, your outcomes may not be optimal. Right. So one of the other problems with clinical expertise is that although with more and more practice and experience, your clinical judgment will improve, your skills, your diagnostic skills, and also in surgery, your technical skills will improve. With experience, with just experience alone, your knowledge of the evidence base may not improve. And actually with age, your knowledge or your staying up to date with current knowledge may actually decline. You can obviously avoid this by regularly refreshing your evidence base. But there is reasonably good data that shows that with age, performance might decline, and that's largely due to people not keeping up with the knowledge base. Right. So, so these are some of the reasons why we need to think about evidence-based medicine and see what best we can do to practice evidence-based medicine. So finding the evidence, understanding the evidence, and then incorporating the evidence, the results of the papers that you read into your practice is therefore very important, but doing this in an effective manner is actually quite difficult because there's a lot of evidence out there, and finding the good quality, right evidence that answers your questions requires a lot of time and effort. And that process is simplified, I believe, by a good understanding. If you really understand the principles of evidence-based medicine and apply it regularly, then the time and effort is actually minimized. Okay? Now, the first thing you need to think about to set about practicing evidence-based medicine in your day-to-day clinical work is to first think about the kind of questions, clinical questions, where you need help from evidence-based medicine, clinical questions that need answering in your day-to-day practice. And just thinking of appendicitis, I've made a list of a few questions here. So the first question is, can I improve the accuracy of the diagnosis of appendicitis? Right? The second question is, does postoperative use of antibiotics reduce infection? Then you've got a question that asks, do trainees do as well as consultants, or maybe better than consultants, when it comes to looking at outcomes after appendicectomy? Then you might be interested in what's the right way or the optimal way, if there is one right way of securing the base of the appendix. Is postoperative follow-up and secondary care necessary, or can you just discharge patients back to the GP after appendicectomy? If you don't do an operation, what can I use to predict recurrence after conservative management? So these are examples of clinical questions that address practical problems. Now you could, if you're really interested, ask questions such as, what causes appendicitis? What does the appendix do in terms of its role in the immunological system and its response to bacteria in the gut? But these questions aren't necessarily addressing practical problems. They are important, they are interesting, but they're not necessarily practical, right? So these kinds of questions are what are referred to as background questions in the realm of evidence-based practice. The questions that we discussed about, the list about, are referred to as foreground questions. So when you're reading about evidence-based practice and evidence-based medicine, you might come across these kinds of questions called background questions and foreground questions. Now, just focusing on the foreground questions, and that's what we're going to do now, it is useful to classify these foreground questions into 3 or 4 main groups. The first group is questions about diagnosis, and this also includes screening. So is one diagnostic test better than the other? That'd be a typical question. The second group is about interventions and their efficacy and effectiveness. So this falls under the category of therapy and prevention. So is, for example, laparoscopic appendicectomy better than open appendicectomy? That would be a question. Is so one analgesia better than the other? One set of antibiotics better than the other, and so on and so forth. The third kind of question or group of questions, clinical questions that are practical, would fall into the category of prognosis. So what's the prognosis of this particular condition, or what's the natural history of a particular sort of complication? And then there's another miscellaneous group that includes questions relating to etiology, harm, quality of care, quality of life, costs, and so on and so forth. Some of these overlap quite significantly with the first three groups that we discussed on diagnosis, therapy, and prognosis. So grouping these questions then would lead you to look for the appropriate study design or the ideal study design that will help you answer the question. And here we're talking about primary research. We're not talking about secondary research or systematic reviews, where you group all primary research on a particular question and then try and collate the evidence and come up with a summary or a summative answer. So, for example, for diagnostic and screening questions, the ideal study would be a prospective study with a blind comparison with your standard. For therapy questions relating to treatment, a randomized controlled trial, as you would expect. For prognosis and prediction, you ideally need a cohort study. And in the miscellaneous category, it really depends on the type of question. For example, for questions relating to incidence or etiology, you would want a cohort study to answer that question. For questions on prevalence, a cross-section study would be ideal. And for questions on the other issues like harm and quality of life and cost, the study design really depends on the kind of question, but usually a randomized controlled trial would be appropriate. Now we'll talk about these study designs in a later talk, but I thought I should introduce you to clinical questions and the ideal study design for different types of clinical questions. Okay, so now a few things to keep in mind when talking about evidence-based medicine. Now, there's a lot of focus on what we call empiric evidence. Empiric evidence relates to evidence that evidence from the real world, evidence from data that is observed, right? So, and many proponents of evidence-based medicine base all of their arguments around having empiric evidence, and very often ignore mechanistic evidence, by which I mean if there's good pathophysiological rationale that something will work, that often gets ignored with the proponent saying, well, there is no RCT evidence, and therefore we're not going to employ that treatment. Now, this is often a problem in medical practice when you deal with drugs and medications. But in surgery, we have tended to go with the practice that if something is likely to work, we just get on with it. And a really good example of this in general surgery is the adoption of laparoscopic cholecystectomy. Now, laparoscopic cholecystectomy very rapidly became the norm or the standard in dealing with gallstone disease without randomized controlled trial evidence saying that laparoscopy is better than open cholecystectomy. And that was because the benefits were very, very obvious. The rationale was there. You didn't have to do a big muscle cutting incision, and that increased inflammation and morbidity and so on. So there was so much mechanistic explanation for it that we didn't really wait for the gold standard randomized controlled trial to come along to show that laparoscopy is better. However, so the point here is that you should not ignore, I think, the pathophysiological rationale. Although if there's empiric evidence that is much better, you should always consider the mechanisms as to how an intervention would work, as opposed to just seeing if it works in the real world. Now, if you are writing a protocol for a Cochrane review, if you're doing a systematic review and meta-analysis as part of a Cochrane review, you will find that the Cochrane want you to write about mechanistic evidence. They want you to write a paragraph or two about how the intervention might work. So obviously, people do give importance to mechanistic evidence, at least the importance it deserves. Right. The second thing to think about is you may have all come across this pyramid. this pyramid of studies that gives you an idea of the importance of different study designs and the levels of evidence they provide in helping you make a particular decision. Now, you might have come across this problem, and the problem is that many of the proponents of EBM would love you to think that the RCT evidence is the best available evidence. It often is, but not always. Now, a poorly performed randomized controlled trial might actually not be that worthwhile or less worthwhile than a well-done cohort study, and that's often ignored. Often evidence from a randomized controlled trial, however poorly it may be done, is used to bin or shut down really good quality observational evidence. And then that's something you need to be aware of. Right. Another thing is another problem, if you like, in the practice of evidence-based medicine is this thing called the inferential gap. So what is this? Now, if you're drawing evidence from randomized controlled trials to make a particular decision, you need to keep in mind that these randomized controlled trials are often done in patients, in selected patients, patients who fit very neatly your inclusion and exclusion criteria that the trial, the people who designed the trial have implemented or laid down. And therefore, the results may not necessarily be applicable or generalizable to patients who do not fit those inclusion and exclusion criteria, in patients with some unique problems or complicated circumstances. Now, for example, let's talk about appendicitis. And if you're planning to do a CT for a patient with right iliac fossa pain to be able to diagnose appendicitis, and you've come across this meta-analysis and review, a Cochrane review that says a CT scan is one of the best tools that there is, and the diagnosis of appendicitis is highly sensitive, highly specific, so it really trumps ultrasound and all your clinical scores and CRP and what have you. That may not necessarily be true for the patient in front of you, because the patient in front of you might not be the kind of patient that has been included in the RCTs. For example, you might have a patient that has got contrast and allergy, and therefore you can't do the standard enhanced CT scan. You might have to do a non-contrast CT scan, and the trials and the meta-analysis may not have studied non-contrast CT scans. It may also be that you have a patient that does not like exposure to radiation and would like to be treated or managed without any exposure to radiation. Or the patient might be super obese that does not fit into your hospital CT scanner. And therefore, you have a problem. You have a lot of evidence on a particular diagnostic modality or treatment, but you just can't apply that to the patient in front of you. And for many treatments, for many settings, you will find that randomized controlled trials have actually excluded a significant proportion of patients that you will come across in day-to-day practice. And that's what is referred to as the inferential gap. Okay, the other thing to think about is this difference between statistical significance and clinical significance. Clinical significance is the difference that matters to the clinician and the patient. Statistical significance simply refers to the p-value, the probability that the observed results are due to chance. Okay, so it's important to understand the difference, and we might cover that again in another session. So if you have a small trial, you may have some important clinical differences between groups, but because the trial is small and the numbers aren't great, you might not get the magical p of less than 0.05. On the other end of the problem, you might have very large administrative data sets that are being used to address specific questions, and they might, the results from those studies might give you a significant p-value very easily, even if there is not much difference between arms. So even if the clinical improvement is only marginal, or the clinical effect size is very low, you'll get a significant p-value. So that's something to be aware of. The other issue with trials particularly is that trials tend to measure outcomes or tend to focus on primary outcomes that are easily measured. not primary outcome, not outcomes that need to be measured. And often trials will use surrogate outcomes because waiting for the final all-important outcome that matters to patients might make the trial too expensive or too lengthy. And in many trials, outcomes do not reflect, even secondary outcomes do not reflect what patients would like to be informed about. And the last thing to keep in mind is that the issue with reporting bias. So articles with negative results don't get published or are published in very low impact factor journals, and they don't necessarily reach a wide audience. And the fact that there are many studies in the literature, including randomized controlled trials and the systematic reviews and meta-analysis that are poorly done, and the quality of evidence is rather poor. But just because it is published, people will start to quote the systematic review or the meta-analysis and base the results of that poorly conducted study to guide their decisions. Okay, so we've come to the end of this talk. So to summarize, we talked about what evidence-based practice or medicine means. I hope I've explained why it's useful for us to practice evidence-based medicine and how it helps us in our decision making. We went through some kinds of questions that EBM can help in answering. We talked about background questions and foreground questions, and how foreground questions can be grouped into different categories, like questions addressing diagnosis, questions addressing prognosis, and so on. We then talked about some of the pitfalls of evidence-based practice. So keep in mind that we shouldn't ignore pathophysiological explanations or mechanisms and then only focus on empiric data. We shouldn't do that. You should be aware that RCTs may be poorly done, and that observational studies that are done really well might be better than RCTs in many instances. We talked about the inferential gap, where the results of RCTs don't necessarily apply to patients in front of you. We talked about statistical versus clinical significance and how we should be focusing on clinical significance. We talked about outcomes that are not necessarily important, that can be the focus of trials. We talked about low quality evidence and reporting bias. So that's it. That's it for this talk. I hope that was useful. If you do have any questions, let me know.
Thank you everyone for tuning in and listening. Until next time, keep running your life with our surgical podcast.